Good evening. This is my soap note presentation titled Bloody Nose by Neander Tabingo, Frontier Nursing University, NP702, Fall 2016. Subjective data. Chief complaint. My nose has been bleeding periodically on the left side and it's bright red. History of present illness. This 73-year-old white female presents in clinic with complaint of spontaneous, moderate, brisk, bright red, painless nosebleed for the last half hour. Has been experiencing small amounts of painless left-sided nosebleed, mostly in the mornings and lasting a few minutes each time, once or twice a week for the past 4 weeks. Resolved spontaneously after pinching the nostrils. Denies left nasal blockage, headaches, loose teeth, or deep ear pain. Denies picking a nose or forceful nose blowing. Currently taking Plavix and ASA for stroke and MI prophylaxis. Denies history of bleeding disorders. Past medical history, MI and CVA 7 months ago, no residual weakness. Denies head or neck tumors, bleeding disorders, hemophilia, or liver disease. Active medical problem, hypertension. Family history, mother alive, dementia, CVA. Father deceased, lung cancer, ETH abuse. Sibling, one brother alive, hypertension, COPD. Maternal grandmother deceased, CVA, breast cancer. Maternal grandfather deceased, DM, heart attack. Paternal grandmother and grandfather deceased, unknown history. Surgical history, hysterectomy 1971, tonsillectomy at 15 years old. No previous nasal or sinus surgery. Social history, drinks 1/2 glass of wine with dinner, denies tobacco or illicit drugs, lives with husband and 2 dogs. Allergies, no known allergies. Medications, Plavix, 75 milligrams PO daily times 7 months. ASA, 81 milligrams PO daily times 7 months. Metoprolol, 25 milligrams PO BID times 1 year now. Immunizations, flu, October 2016, pneumovax 2012. Review of systems. HENT denies head trauma, headaches, facial pain, visual problems, sinus pain, nasal insertion of foreign bodies, nasal congestion, loss of smell, feeling of blood, dripping down the throat. Integument denies easy bruising. Cardiovascular denies chest pain or pressure, palpitations, dyspnea and insertion, orthopnea, dizziness, fainting, lower extremities edema. Denies asthma, shortness of breath, wheezing, hemoptysis, cough, lung disease, or history of bronchitis or pneumonia. Gastrointestinal denies nausea, hematemesis, abdominal pain, diarrhea, constipation, indigestion, melena, rectal bleeding, hepatitis, or other liver disease. Genitourinary denies hematuria, vaginal bleeding, or problems. Neuro denies neurological deficits, seizures, ataxia, headaches, dizziness, or forgetfulness. Hem-onc denies cancer or other blood disorders. Objective, general appearance, vital signs, temp 97.2, pulse 89, respirations 22, blood pressure 140/65, O2 sat 97 room air, height 167 centimeters and weight 60 kilograms. Constitutional, well-developed, well-nourished elderly female, appears stated age, in mild distress, alert but slightly agitated, talks in sentences. Physical exam, skin, warm, pink, dry, no rashes, pallor, purpura, petechiae, or telangiectasias. HENT, head, no facial swelling or deformity, eyes, no conjunctival hemorrhage, sinuses, no sinus tenderness, nose, bright red blood, left nasal sputum, septum, no masses, no septal deviation, limited exam due to bleeding. Right nose, pink intact nasal mucosa, mouth, mucous membranes, gums, tongue moist, pink without lesions. Heart, regular rate and rhythm, S1, S2 clear, distinct, no murmurs, JVD or edema. Strong peripheral pulses. Lungs, clear lungs, lung sounds in all fields, full expansion, no chest wall tenderness. Lymphatics, no cervical nodes enlargement. Assessment. The diagnosis is epistaxis anterior bleed. Definition, Epistaxis is a Latin term derived from the Greek words epi, meaning above, and stasion, to drip. It is one of the most common ENT emergencies to present to primary care practitioners. Yao, 2015. GARG 2015 defines epistaxis as bleeding from the nostril, nasal cavity, or nasopharynx. It can range from recurrent mild bleed to severe life-threatening emergency. Sarhan and Algamal, 2015. Etiology: local, trauma, facial trauma, or local irritation from picking, forceful nose blowing, neoplasia, URI, chronic sinusitis, exposure to irritants, cocaine abuse, allergies, angiomas, nasal steroid sprays, and septal abnormalities. Causes: granulomatous diseases like Wegener's and sarcoidosis, hereditary hemorrhagic telangiectasia, infection, bleeding diathesis, malignant hypertension. Environmental causes are dry indoor environment and lack of humidification, dry winter months with changes in temperature and humidity, and circadian rhythm where epistaxis are common in the morning and late afternoon. Yao, 2015. Gurul, Molly, 2014, and Garg, 2015. Medications. They include NSAIDs, warfarin, clopidogrel, and factor X inhibitors. Yao, 2015. Idiopathic cause is unknown cause. Pathophysiology. The nasal cavity receives blood from the internal and external carotid systems and is therefore very vascular. Garg, 2015. Disruption of the nasal mucosa by trauma, ulceration, bleeding disorders, inflammation, and neoplasms result in epistaxis. Gurul and Molly, 2014. Risk factors are related to etiology and include nose picking, coagulopathy, acute or chronic sinusitis infections, uncontrolled hypertension, liver disease, alcohol abuse, blunt nose trauma, cocaine use, dry and cold climate, septal deformities, granulomatous diseases, and long-term use of anticoagulants. Hollier, 2016. Prevalence: about 60% of the population will be affected by epistaxis at some point. GARG, 2015. It is the second most common cause at 33% of all emergency ENT admissions after sore throat. Barnes, Spielman, and White, 2012. Dynamed Plus, 2014. It is common in children less than or equal to 10 years old and adults above 50 years old. Dynamed Plus, 2014. 90% of nosebleeds occur anteriorly. GARG, 2015. Death from epistaxis is rare. In 2005, there were 7 deaths related to epistaxis in the US, all aged 75 and older. Barnes, Spielman, and White, 2012. Common symptoms. Anterior epistaxis is usually unilateral, continuous, moderate bleeding from a group of blood vessels in the anterior septum called the Kieselbach plexus. Most are venous, but arterial source becomes common in advancing age due to mucosal and vascular atrophy. It is the most common site for those taking antiplatelet agents. Anterior bleeds account for 90% of epistaxis incidents. Gurul and Molly, 2014. Posterior epistaxis is intermittent, brisk arterial bleeding flowing posteriorly into the pharynx, common in the elderly and those with severe facial trauma. Gurul and Molly, 2014. Hemoptysis, nausea, vomiting from swallowing blood, hematemesis, melena, and from posterior bleed or anterior bleed with high blood flow. Yao, 2015. Hollier, 2016, and Dynamed Plus, 2014. Differential diagnosis. Because epistaxis is a symptom, Hollier, 2016, I have decided to do differential diagnosis based on etiology. First, I came up with the presence of a tumor that could be anterior considering the unilateral nature of the bleeding, and because of poor visualization due to bleeding, this cannot be ruled out. Second, bleeding tendency associated with antiplatelets or thrombotics is also most likely due to the locus Kieselbach, which is in the left nasal septum, as the apparent source of bleeding according to the physical exam. And third, idiopathic epistaxis because of the apparent source of bleeding in the left nasal septum. Essential Evidence Plus 2014. I did not consider ruptured carotid artery aneurysm or traumatic carotid cavernous fistula, as these are severe forms of bleeding that will not probably present in primary care. Immediate treatment, adult epistaxis management. Foremost is to protect airway and assess cardiovascular status. Advise patient to sit and lean forward so blood does not run down the posterior pharynx, and hold emesis basin to catch any bleeding. Have patient pinch nostrils, not the bony bridge of the nose, to apply direct pressure to septal area for 10 to 15 minutes. Anterior packing with Maricel or procoagulant dressing such as calcium sodium alginate for our patient, and antiplatelet therapy might be useful. Dynamed Plus 2014, Barnes, Spielman, and White 2016. Medications. In the clinic, oxymetazoline is the first-line treatment. Silver nitrate applicators may be used once site is identified. An alternative for patients and antiplatelets, like our patient, would be the use of procoagulant dressing such as calcium sodium alginate. Dynamed Plus 2014. Diagnostics. Gorol and Molly 2014 state that lab studies are ordered on the basis of findings from the history and physical exam. Usually, no lab test will be ordered for epistaxis that is not severe, that a history of Plavix and ASA will warrant checking the hemoglobin and platelet counts. Hollier 2016. Medication side effects. Oxymetazoline, minor side effects are burning, dryness, stinging inside the nose, sneezing, and rhinorrhea. Have the patient report immediately to prescriber if there is angina, tachycardia, passing out, severe headache, or severe nasal irritation. Educate patient about signs of a significant reaction like wheezing, chest tightness, fever, itching, skin color, seizures, or swelling of face, lips, tongue, or throat. Drugs.com for Professionals 2016. Care should be taken when using silver nitrate applicators for patients with history of nasal surgery or those taking antiplatelet agents. There is a risk of further bleeding and septal perforation. Gorol and Molly, 2014. Patient education. Instruct to avoid trauma to mucosa by avoiding picking, excessive rubbing, excessive and forceful blowing. Keep septum well coated with vitamin A and D ointment, petrolatum-based zinc oxide, or OTC bacitracin ointment until site is healed. Teach home remedy for minor recurrence of bleeding by first spraying Afrin nasal spray to bleeding mare, then packing the site with cotton pledget soaked in Afrin nasal spray and applying it for 10 minutes. Consider use of OTC nasal Cs, a calcium alginate-based packing that can be used at home. Explain importance of humidifying the home, partially opening a few windows, placing water in containers near radiators or stoves, obtaining a humidifier. Consider stool softener to prevent bearing down and increase risk of nosebleed. Gorol and Molly, 2014. Consult or referral. Possible tumor to ENT. Recurrent bleeding despite treatment, hematology, or hospitalization if severe. Bleeding not stopped by tamponade could be posterior bleeding and needs to be sent to the hospital right away. Dynamed Plus 2014, Gorol and Molly 2014, Yao 2015. Follow-up. Call the clinic if home treatment fails. Follow up within 24 to 48 hours after nasal packing for anterior epistaxis. Earlier follow-up recommended if bleeding, fever, drainage, or increased pain. Consider leaving PAC in for 48 hours if anticoagulation medication such as warfarin, or if there's high-risk cardiac risk, or hemoglobin less than 9. Irrigate packing with 5 to 10 ml saline and wait 5 to 10 minutes to prevent material from sticking to the mucosa before removing the pack. If bleeding does not resolve, suspect posterior epistaxis. Remove all packing for posterior epistaxis within 48 to 72 hours to prevent tissue necrosis and infection. Advise patient to avoid picking or blowing the nose for up to a week and to prevent bending or overstraining. Dynamed Plus 2014. Health promotion. Avoid alcohol. Patients with epistaxis were likely to have consumed alcohol within 24 hours of presenting at the clinic or the hospital. Alcohol and clopidogrel don't go together. Manage hypertension to prevent malignant hypertension, which may predispose to epistaxis, although there is weak evidence in relationship between hypertension and epistaxis. Prevent upper respiratory tract infection. Lubricate nares often. Humidify at night and at winter time. Stop smoking. It dries the nasal passages. Yao 2015, Hollier 2016. Pharmacologic treatment. The treatment guideline for epistaxis from the American Academy of Physicians is 11 years old, hence was not referenced here. Afrin or oxymetazoline 0.05 nasal spray is first line. Spray twice into each nostril. Have patient pinch nostrils tightly for 10 to 15 minutes. Oxymetazoline spray as sole therapy reported to resolve epistaxis in 65% of patients in one study. Gelatin, thrombin, hemostatic matrix sealant or flow seal is reported to resolve bleeding in most patients with epistaxis and appears more effective than nasal packing. Tranexamic acid soaked pledget may resolve bleeding and reduce risk for rebleed more effectively than anterior packing with epinephrine and lidocaine soaked pledget in patients with idiopathic anterior epistaxis. Procoagulant therapy like calcium sodium alginate nasal packing for patients on anticoagulation or antiplatelet therapy may be more effective and preferred over local treatments such as cautery. Dynamed 2014. Silver nitrate 95% should be used with caution in the elderly or those with epistaxis resulting from antiplatelet therapy. These patients have friable blood vessels. Other modalities. Electrocautery or with silver nitrate is recommended next to topical vasoconstriction with oxymetazoline. Silver nitrate may be applied in the clinic, used with caution in the elderly and those on antiplatelet therapy. Nasal packing is the next step after cautery. May pack anteriorly in the clinic, but posterior packing best done by ENT or in the ER. Barnes, Spielman, and White, 2016. Diet. Hot foods can trigger nosebleed. Yao, 2015. Activity. Strenuous activity, bending, straining, nose blowing, all put the patient at risk for recurring nosebleed. Dynamed Plus 2014 and Yao 2015. These are my prescriptions for Afrin nasal spray and Dacitracin ointment at home. And here's the diagnostic test for CBC. Here's my references. Thank you for listening.